and so I bounced around over the years. And as you know, I've been working in the Heart Center for about a decade, and I'm not going to talk too much about that, although hopefully I'll leaven a bit the research with some clinical experience. But I think I can thank Lori for the invitation to come here, so thank you. I do some consulting. This is all pain-related consulting, so it doesn't affect this particular talk. So I'd like to start with this New Yorker slide, and here's a guy, almost looks like he could be a parson, and he's saying, "Oh, not too bad, except that my heart aches." Lock I had drunk, and you, are you okay? So my question to you is, does this guy have heart failure? Does he have both? And my point is that they feel pretty much the same to patients in many ways. They are both vitality sapping illnesses that feed off of each other. This is one of my attempts to characterize the cycle between heart failure and depression. Initially, I'll show you that depression increases the risk of heart failure in vulnerable adults with things like systolic hypertension or cardiovascular disease. Depression also increases the risk of mortality through things like poor adherence, functional decline, hospital readmission, and increases overall health costs in patients with heart failure. Heart failure also circles back and increases the risk of incident depression in older adults. What has not been shown still is that treating depression improves heart failure outcomes, specifically mortality, but there's a little nuance to that too, so I'll get to that as we go along. So this is an attempt to summarize a lot of studies of the prevalence of depression in heart failure patients. Some of my studies are on here. The consensus estimate is down here, which is a little over 20%. So that is a significant number. That's about 1 in 5 of the patients that you're caring for. As you might suspect, it's the sicker patients that are more likely to, with prevalence rates going from about 11% in NYHA class 1, 20, 40, 42%. What I want to draw your attention to in this is that NYHA class is not, it's a functional. So actually NYHA class is not itself independent of the depression status. That you can become more functionally impaired and more symptomatic because you're depressed. And I have seen patients whose functional class improves when their depression improves. So there is clearly heart failure severity is relevant to whether you have depression, but also depression circles back to affect heart failure severity. So this is a quite old image, but I couldn't really find a better one these days. We haven't completely rediscovered the heart-brain connection. So this lets me just talk about the various pathophysiologic ways in which depression might affect cardiovascular disease. First, let me remind you that the clinical syndrome of major depression isn't just a low mood, but it's also a set of essentially neuroendocrine abnormalities, decreasing sleep, decreasing sex drive, appetite, concentration, etc. That's thought to be tied up with things like excessive CRF secretion in the CNS, as well as hypercortisolemia. We've got essentially a hyperactive HPA axis and a hyperadrenergic state where the balance between sympathetic and parasympathetic is altered in an arrhythmogenic manner. There's also increased pro-inflammatory cytokines. Did a little research with that with Wayne way back when. So to just summarize this in more of a list kind of way, so depression is bad for heart disease partly because it's characterized by a high sympathetic tone. Although people look sluggish, they're actually in a state of arousal and alarm, which produces reduced heart rate variability, particularly the low frequency kind, elevated circulating catecholamines. It's also associated with platelet activation, so it's prothrombotic. This is through dysfunctional serotonin signaling. I don't know if you know this, but they often test new antidepressants on platelets because platelets have a lot of the same serotonin receptors as neurons. And there's increased procoagulant factors like platelet factor 4, beta thromboglobulin. We've talked a little bit about the HPA axis and accelerated atherosclerosis, elevated free fatty acids, low omega-3 fatty acids, and generally the pattern is that the pro-inflammatory cytokines are elevated like CRP, IL-2, IL-4, IL-6, and TNF-alpha, while the anti-inflammatory cytokines tend to be suppressed. But that's not the half of it. Pathophysiology likely is not the most important or main way in which depression affects outcomes in heart disease, because they really affects behavior. As you well know, depressed patients are about 3 times less likely to adhere to their meds. They are also less likely to follow lifestyle recommendations like exercise or quit smoking, practice self-management, follow up, like even show up at the clinic. And it's a little harder to quantify these things in terms of their role, but they probably help account for the mortality effect of depression in heart failure patients. So let me get into some specific studies at this point. And there's a number of them that show that among vulnerable patients, that heart failure is caused by depression, but in vulnerable subsets of patients. So in older patients with systolic hypertension, the depressed ones have heart failure for 4.5 years. Among people who have coronary disease, acute coronary syndrome depression, the ones who continue to be depressed have about a 50% risk of developing heart failure. In this study, it wasn't affected by antidepressants. The bulk of the research is more about what happens with depression in people who already have heart failure. So there's a whole raft of studies. I'm only picking out a few here. Hospitalized heart failure patients with depression, mortality or rehospitalization in 12 months. When you summarize, showed depression, increased cardiovascular or all-cause mortality. I pulled up a paper just out in 2016 showed that this effect lasts for up to 20 years. And that's not because depression is that potent, but more because it's a recurrent or chronic condition. So having been exposed 20 years ago, you're likely continuously exposed to that risk factor. This is a nice slide because it shows that there's a nice dose response curve. This is from Jang at Duke. And so if you look at this is the group with no depression, mild depressive symptoms. This is kind of mild, major depression, and moderate. So this is a Kaplan-Meier curve showing that survival becomes less and less likely over time, particularly in the depressed group. So this was heart failure in patients followed for about 2.5 years. In heart failure trials of various different kinds, depression has been monitored, followed. This, for example, is some data from SCUDHAP, where 157 heart failure patients, as you're familiar with the trial, randomized to defibrillator and amiodarone as an endpoint of all-cause mortality. Depression, and this was not major depression, which was done by interview, it's affect depression, so they just had symptoms, and after controlling for demographic, clinical, and other psychosocial factors, depression and social isolation, but not anxiety, predicted mortality. There's another trial. This was a rate versus rhythm control study in patients with heart failure and atrial fibrillation. Here, a little bit lower cutoff, but they were able to show that cardiovascular mortality hazard ratio was up about 60%, arrhythmic death was up, and even all-cause mortality was up. So there's also another factor. Social isolation is an additional factor that has been important. So unmarried patients were shown to have additional risk in this study as well. We did a study now quite a while ago. I was curious as to what financial impact, right? Isn't that what it all comes down to? Don't they say follow the money? So we looked at 1,100 that had a first hospitalization with a primary diagnosis of heart failure. And we looked 2 years before and a year after at their utilization and costs. The diagnosis was confirmed with a chart review. We had a cardiologist who helped us look and make sure that everybody really had heart failure. And we formed 3 groups. There was a group, no evidence of a depression. That was the bulk of them. There was a group that had just gotten an antidepressant script and no diagnosis. We looked in the charts of 50 random people. It looked like they were getting it because they were distressed. It wasn't just for pain or for insomnia. And then there was a group that had both an antidepressant and a depression diagnosis. And we thought, well, that was probably the sickest group. We excluded 20 patients who got a depression diagnosis and no antidepressants. They were pretty atypical patients. So what we basically found is it was between 25 and 30% increased total health care costs in these heart failure diagnosis group, 26% in the antidepressant only group. And of course, the point is that it was all medical utilization, inpatient and outpatient utilization, but not mental health use. As you can imagine, these are old patients. They're allergic to psychiatrists. They didn't go. So the median mental health use was 0 days in all groups, although the depression diagnosis group had a little more utilization than the antidepressant group. So I'm going to go back to some of the earliest research that I did with Barb Crane and Wayne Levy, and I just want to review it. When I was in medical school, I was we were not surprised. Were worse in the heart failure patients that were depressed. Related to depression was the symptoms of it. And this gives the kind of the story. This is a cohort. Specific quality of life measures like the Kansas City a rather simple role interference score having to do with interference with work, social, and family also showed a clear dose response to depression. So there's a whole bunch. This is an older slide, but there's a lot of studies now having shown a relationship between depression and heart failure clinical outcomes. Just to give you at least one glimpse into the opposite side, heart failure, as you might expect, can be a pretty depressing condition to have. This was a study, a Dutch study of 5,000, 5,100 residents of Rotterdam, followed for 9 years. in heart failure was associated with about a 66% increase in depression. So now I would like to switch talking about treatment. And here's a young lady talking about this next which I used to use a lot of until the FDA said it was a bad drug for QT interval. I still like really tolerated, doesn't have drug interactions, etc. As you well know, I've written a lot of scripts for that. So this is where the heart failure story is a little more negative. I don't know, not so impressive. So the SAD Heart CHF study was done on a Duke. They randomized 469 patients over 45 years old with heart failure and ejection fraction less than 45% and major depression. They got 12 weeks of sertraline, which is Zoloft, 50 to 200 milligrams a day. All received some nurse support every 2 weeks. But I think the crucial thing to notice before we get onto the cardiac stuff is that they weren't, through that intervention, able to produce a difference between the treated and the untreated group. You're never going to find an effect of treating depression in heart disease. And they didn't. They didn't really get much of a difference in depression, and they didn't get much of a difference in heart disease outcomes either. This is what the lines look like. Do you think that's significant, Phil? Probably not. So there were no differences in response by dose, new NYHA class, or completers. There were a little bit more dropouts in the sertraline group. Inpatient and outpatients were recruited. They actually had a fairly significant depression score, which was thought to be a problem in previous trials, that they weren't quite sick enough. And then, of course, they tried to blame it on a good placebo response because they had good nurses. Sarah Goodland did a commentary on this, and she said the doses of sertraline weren't high enough. It was 65. Our efficacy data said 145. In fact, depression inventory isn't major depression, although they both met both criteria. And so she came up with a number of suggestions, which is we need to aggressively treat the heart failure as well, comorbidities like sleep apnea, because depression feeds off sleep apnea. Initiate exercise, supportive interventions, up-titrate and switch antidepressants. So I think she's right about these things. You'll see that I think straight SSRI trials in this older, sick population are really just not enough. So my interpretation of SAD heart is this is essentially an RCT of the SSRI sertraline. They didn't really do much else besides that. Not really an RCT of a multimodal depression treatment. And there's good suggestion in other older, particularly medically ill populations that throwing an antidepressant at these patients is often not enough to make them better. Okay. So there's been some other studies. A very recently published trial, a German RCT of escitalopram. That is the left-handed enantiomer of citalopram, Lexapro by name, and 10 to 20 milligrams, 372 patients. And now they kind of trimmed off New York class 1 patients. These are all heart failure with reduced ejection fraction and a very rigorous SCID, structured interview, major depression. So they're trying to clean up the sample for the sicker patients. And they tried to look at the outcome of time to all-cause mortality or hospitalization. About 2/3 of both groups met the outcome, and there was no difference between the two. Why? Look at the depression change. It was exactly the same in both groups. They weren't able to produce a significant depression difference by putting people on the treatment, so they didn't get any heart disease outcome changes either. Here's another one. It's a little different. This is not a depression-focused intervention, nor is it a depression intervention. It's a disease management program. So this was the COACH RCT, reported in JACC in 2010. The disease management program included no depression intervention, but in nearly 1,000 heart failure patients, 39% screened above a threshold, And interestingly, in the non-depressed group, the disease management program helped with the chosen outcomes, and in the depressed ones, it didn't. It actually made them worse. Don't know why that happened. So this is a trial that I was involved with. John Rumsfeld, who is works with the VA cardiology, he's in Denver, ran this trial. And we tried to do it a little differently than the other trials. Nearly 400 heart failure patients with poor health status. And what do we mean by that? On a disease-specific quality of life measure, they scored 160 on the KCCQ, Kansas City Cardiomyopathy Questionnaire. And they were randomized to a collaborative care. And that included depression treatment for anyone who had a PHQ score greater than 10. And it was conducted at 4 VA hospitals, including Seattle. And what happened is there was a collaborative care team of cardiologists, psychiatrists, primary care internists, and a nurse, and they made recommendations for the PCP for 6 months. We followed the patients for 12 months. Depression treatment it included antidepressants, but it also included monitoring behavioral activation by the nurse, so a little bit more than that. So what did we find? Both groups improved on the KCCQ. So that measure that we screened people in was also our outcome measure. We looked on trying to improve quality of life and functional status. Both groups improved. We did not get significant differences between the groups. But for reasons we still don't understand, we got fewer deaths. Less than half. 8 out of 187 people in the intervention group died versus 18 in the control group, although there was no differences in hospitalizations. We did get a significant difference in depression. Among the subset of intervention patients that were depressed, we did get an improvement in depression. So, we don't know what this means. That's kind of what we're left with. We got a little bit of a confusing finding. So what I want to do is draw a contrast to the impact trial. My chair, Ergen Unitzer, has kind of revolutionized the whole way that psychiatry now depression care managers depressed patients flexible He did not specifically look at heart outcomes nor patients with heart failure, but I would say this is a more robust kind of clinical intervention for the older, ill, depressed patient because it allows you to A, switch drugs, you're not tied to a drug, and B, supplement, pharmacologic effects with behavioral effects. There's also another trial. This was run out of Cornell. They looked at 600 primary care patients over 60, randomized to depression care management. They got double the decline in suicidal ideation, higher remission rates, and the minor depression group did well regardless of the intervention. So in conclusion, what I want to say is the epidemiologic data on depression in heart failure is clear. Depression predicts the onset of heart failure, mortality, and rehospitalization. It's a big factor in costs and utilization. Depression predicts symptoms, function, health-related quality of life, and costs better than objective heart failure measures such as ejection fraction, MVO2, BNP, systolic blood pressure. But we have not shown that treating depression improves heart failure or, frankly, coronary disease outcomes. Why is that? Depression, number one is that the depression intervention you're not going to, an old rule of thumb in epidemiology is you show something as a risk factor. Social isolation is a risk factor for this, or elevated blood pressure is a risk factor for that. With a treatment for the risk factor, you never erase the full effect of the risk factor, maybe half. And we can't even get the risk factor down. You know, we're going to erase maybe half the depression effect on heart disease if we treat the depression. But first, we have to figure out how to get the depression. So I think we need more robust multimodal interventions. And this is where I'm going to come to my experience over the past decade in the Heart Center, which is we put most of the people that I see on some med. But I like to think that we're not solely doing medications. And as you well know, this is a group of people that are have a lot of problems. In many ways, they're very shut down. You know, they may not be getting out of bed. They're not doing anything. So we work with them on that. We also switch meds. We supplement with things, and hopefully we get a little bit better results. It can be challenging. You know, I hadn't really imagined treating people with LVADs and stuff like that when I started in the clinic. And, you know, I mean, there's limited amount you can do about social and physical reactivation, but it's not hopeless. Have been able to help things out. So that's about the end of my talk. So there's plenty of time for questions. Yeah, Jeff.